of covering 20 million people. We're a country of about 200 million. We're still a long way from nearing universal health coverage. But it's not all doom and gloom, because we've seen that there has been an increase. Of course, there are things that we need to do to sustain the increase. We are not yet there. We need the service-wide mandate to enforce the mandatory nature of insurance. A lot of our people are still not aware. We need to increase awareness. We cannot be it alone as NHIA. We need to ensure that we work with other stakeholders to move that forward. Trust is not there. It's just being revealed. And so what I have tried to articulate is, we recognize challenges exist, but we can't sit down and fold our arms because of the challenges. We are trying to tackle them head on, and we are sure that with your support, we will do a whole lot more. But as people that are accountable, we need to give account of what we have done so far, and that is what we are trying to do. Of course, I have a long list of things to ask. That is, I didn't want to lead with that, because I also feel like it is the responsible thing for us to do, to say, since we last met, sirs, these are the things that we have done so far. And we have worked hard. There have been some progress, but a lot more progress needs to be done for Nigeria to get to where it must get to. In terms of the funding in that basis, there are funding gaps. If we want to cover more of the vulnerable people in Nigeria, we will need a lot more money than what we currently get in the Basic Healthcare Provision Fund. We've covered 2.7 million people so far. But when we look at how many Nigerians are living, even if we just take one index, those that are poor, income poverty, or living in multidimensional poverty, or you look at data, there is a lot more people than that. We're talking about the 40s and 50s of millions of people that need to be covered. This already presents a resource challenge. But can we also, in this era where we have seen funding everywhere is constrained, part of it is more funding, part of it is more value for the money you have. So what we have tried to do is squeeze the one that we have to see how we can do more. If we have more money, we're saying that NHI is a good bet in how we can cover Nigerians' healthcare, because we can do more even with the money that is given. So funding gaps exist. We also have institutions that maybe have not remitted funds to NHIA that they were supposed to cover Nigerians that exist. We will come to the committee with a list of MDAs that owe the NHIA money to cover people, sometimes for people that we have already covered, but we're still awaiting the resources. One of the big challenges we face is that in insurance, it's typically supposed to be no payment, no cover, no premium, no cover. But we don't want to leave Nigerians stranded. So several times NHIA would have to go ahead and cover with the anticipation and expectation that the funds will come. Sometimes these funds for years we don't get it. So we have done a compilation of where NHIA is in. People are indebted or organizations are indebted to NHIA, and this is one of the key asks we will come to the committee with a validated list of those so that we can provide that to your good selves. In terms of complaints, I believe that the complaints raised by the honorable member are valid. These complaints have been going on for a while. That's why I mentioned that in 2024, over 2,000 plus complaints were handled. If everything was all rosy, and there would not be complaints. But what we're saying about complaints is that when people complain, it means they actually still have hope that something can be done about it. We don't want a situation where people stop complaining, because that means they have given up entirely and have no expectation of anything being addressed. But what we're trying to do in NHI is say, please bring the complaints. But what we hold ourselves accountable for is, are we addressing those complaints? What percentage of those complaints have we resolved? And that is what we hold ourselves accountable for, that every management meeting, this is something that we continue to review. So, sir, there are complaints. Or there are things that are happening in the system, but what we're saying is that NHIA we have set up an entire department just to focus on addressing these complaints. Some of them we're able to address, some of them we might not be able to address in the time frame. And that's why in some instances we have started sanctioning both hospitals that are erring, commending those that are doing well by Nigerians in terms of the quality of service they are providing to enrollees, but sanctioning those that are not doing the right thing. Because intention has to be backed by enforcement. Now, can more be done? Absolutely. And we are starting on this journey of enforcement, and we will continue to go on the journey on enforcement. The same thing about services that people get. It's really important to, some of it is tied to the complaint, but some of it is tied to also awareness. If I have health insurance coverage and I know for sure that I have an acute appendicitis and it is covered, if I go to the hospital and they are not covered, I will complain immediately to NHIA. We want that, because then that is a sanctionable thing that we can provide to providers. And if the providers know that we are watching them, then this was done. And that's why, Mr. Chair, even within NHIA, right now we have most of our state coordinators and directors go to these facilities, almost some form of mystery shopping. It's now something that we do. If you live in a particular neighborhood and there are 10 NHIA accredited facilities, just go. And this is something that operationally we're supporting. See how enrollees are being treated. Document. At the end of the meeting, introduce yourself to the medical director and make a formal feedback on what you've seen and let us know. Because that's what's going to strengthen the protection that we're providing for the enrollees we have. Of course, if things were going well, we would not need all these interventions. But what we're saying is that there are challenges, a lot of them. But we are also doing XYZ to take on and to tackle some of these challenges. And that's what these are the things we have started doing to address the challenges. And this is the traction that we're seeing so far. And we will continue to strive to make sure that those challenges are addressed. But at 20 million our state, it's not where we want to be as a country. We feel we should do more. We feel more people should be covered, especially people on vulnerable. That's why even for the programs on the CMO, which is the fistula program, as well as the obstetric care, what we say is, and our approach is, first keep the women alive, and then let's insure them afterwards, so that they also add to the pool of insurance, so that after that particular episode is over, if you have any issue in the future, it will be covered. And we're working with our state health insurance counterparts to make that happen. The program started in about October last year, but we have started the pilot in the centers in Kano and one in Akwa Ibom about August, where we're piloting, but then doing the proof of concept. But the full program started October, November last year. That's when we started implementing. And that's why right now, roughly about 7,000 women have benefited from this. And those numbers are gotten by independent verification of claims that have been submitted and verified for the services that were provided. And that's how we come up with the numbers of people that have been benefiting from it.